that diabetic foot problem is a major health problem, is a very big problem. And among all possible complication of diabetes mellitus, diabetic foot problem are the leading cause of the hospitalization. Diabetics have 15 to 30 times more risk of amputation compared to non-diabetics, and greater than 70% of non-traumatic lower extremity amputation occurs due to diabetes. And if a patient has diabetes, there is about 15% chance in its life that he will develop an ulcer, and in 15% of that patient, that ulcer will lead to an amputation. So prevention of ulcer in a diabetic patient is actually the prevention of amputation. Because if you take the history of a patient who has underwent a major amputation below knee or above knee, the story will start. There is an ulcer in 85% of the cases, which was non-healing, and it was present for months, and it ended up in a major amputation. So the problem is that the peripheral vascular disease, which is very prevalent in diabetic patients, is neglected. Patient goes into amputation for their gangrenous flows without looking for their pulses, without evaluating for their peripheral vascular disease, and without correcting it up. And it led to non-healing ulcers and in end up major amputation. So there are challenges. There are challenges of education to not only the mass public, but also our medical practitioners. There are challenges how to evaluate a diabetic patient and how to correct it up. So in this session, we will actually try to explore what are the challenges actually in a diabetic patient than a typical peripheral vascular artery disease patient has. So you rightly said that diabetic patients have multiple causes of the ulcer. So anyone can tell what are different types of ulcers diabetic patients have.
So we have ischemic ulcers, neuropathic, and uh, neuroischemic.
Very good, excellent. So do you know about the ratio of these ulcers, different type of ulcers? So, so basically the most common is the neuropathic ulcer. And this is a typical picture which I am showing that diabetic patient due to neuropathy develop foot deformity. They have loss of sensation. They are prone to repeated trauma and develop neuropathic ulcer. But there are 15 to 20% of the patients who have typically ischemic ulcers, and they are present at the peripheries. They are painful ulcers. They have less granulation tissue. And 50% of the patients have a mixed type of ulcer, means they are neuroischemic. So there are three types of the ulcers. The common are also the neuropathic, but neuroischemic ulcers and ischemic ulcers are there. So this is the ladder to the amputation which these patients have. Means first they have the neuropathy, then they have ulcer. If it is associated with peripheral vascular disease and it is infection, it leads to a major amputation. So this was a very good work done by actually Malik and colleagues, which they compare what was the outcome of the amputation rate and the cumulative survival in these patients, three types of patients who are ischemic, having neuroischemic, and neuropathic. So what we see on the left column that neuropathic ischemic ulcer have highest rate of amputation, and the survival was worse in those patients who have ischemic ulcer as compared to neuropathic ulcer. So it is very important to identify the peripheral vascular disease which is neglected in diabetic patients. So if I go on the epidemiological data, 15% of the diabetic patients develop peripheral vascular disease over 10 years of diagnosis, and number reaches up to 50% after 20 years. So in your clinic, the patient if comes with a 20 years history of diabetes, half of them have peripheral vascular disease. The high blood sugar expedite atherosclerosis and promote peripheral vascular disease, leading to reduction of the blood supply to the foot. It is mostly the infrapopliteal segment which is involved, and it is the mostly whole of three vessels in which is involved, and it is calcified typhoid disease, multi-segmental disease. Sometimes superficial femoral artery is also involved. The delivery of nutrients and oxygen is compromised to the foot when there is an ulcer, and it leads to anaerobic infection, which is there. So, if I say, what is the basic challenge from a typical claudicant than a diabetic patient who is peripheral vascular disease? Is there any difference in their clinical presentation or a challenge in their assessing clinically? Any participants want to comment on that? Anam, can you comment on that? Do you have any idea that what is the first challenge when a patient comes, diabetic patient comes to our clinic, and what is the first challenge we have in history and examination? I see Ghulam Ali with us. So the first challenge we see is due to neuropathy. We have been taught in medical school that patients present with intermittent claudication. They present with either critical limb ischemia. And critical limb ischemia, the patient is having rest pain or they have a gangrene. But due to associated neuropathy, patients in diabetes do not present with typical intermittent claudication. The very first presentation may be like they are presenting like uh, tissue gangrene, or they are presenting like ulcer, which is non-healing. So they do not typically present with intermittent claudication. This is the first thing in history you have to understand, the very first. Second problem is that the vessels are calcified and they are not palpable. So what I will tell you, the third challenge we find, we rely a lot on the ABPI, but the ABPI may not be representative in diabetic patients due to calcified vessels which are not collapsible. So we have to use other non-invasive methods to detect it. So if any patient in diabetes comes to your clinic, you have to check for the pulses. You have to do some non-invasive investigation to detect the peripheral vascular disease which is there. So new combination of neuropathy and the combination of ischemia is not good because neuropathy causes small trauma, and if there is ischemia, the ulcer is not going to heal. It leads to further tissue loss, and it leads to gangrene, and it leads to further loss. So this is the typical presentation which we are taught in medical college, that patient in aorta and iliac disease are involved. Then there is femoropopliteal segment is involved mostly. Then tibial and peroneal segment is involved. But in diabetic, mostly this is the infrapopliteal vessels which are involved, and it is calcified, it's multi-segmental, there are a lot of segments which are involved. Then superficial femoral artery is being involved. And patients do not typically present like intermittent claudication. So if I go, because I see some of the interns with us also, and also junior, I will say intermittent claudication is a leg pain in the muscle group produced by exertion that is relieved by rest, not affected by body position. And usually the arterial segment is above the muscle group. And typical presentation, for example, is superficial femoral artery is involved, the soft muscles are involved. If intrapopliteal is a foot pain, and if there's aortoiliac, there's buttock pain. But this presentation may be atypical also. So we tell our colleagues that leg pain is not always musculoskeletal. So what problem I face that patient leg pain are usually treated with musculoskeletal. No one considered that the other causes like they may be suffering from the neuropathic pain, peripheral vascular disease, or detect the pulses. And when they are ignored, the very first presentation may be a toe gangrene. So it is very important as a whenever you see a patient with leg pain, you have to consider all the possibility, including the arterial insufficiency which is there. So this is the most of this has been discussed that we have to check for the look for the hair loss, muscle atrophy of subcutaneous tissue and skin, any dry fissure skin, discoloration or dependent hyperemia, presence of ulcer gangrene, and then we have to check for the presence and quality of the pulses. And that start from the femoral downwards, popliteal pedal pulses, and also check for the ankle brachial index. So uh, I will say, if the ankle brachial is not representative, what other test we can use to evaluate these patients? Anyone want to share about that? Which other tests we can use to actually detect it up?
So toe brachial pressure index.
Very good. Toe brachial pressure. That is very good. So how we can detect the toe brachial pressure and why it is representative of peripheral vascular disease?
So in the same way as ankle brachial pressure index is taken usually by the calibrated machine that is used to calculate ABPI. The cuff is used for toes, and because the toe vessels are spared in diabetic
Excellent.
vascular compared
Excellent.
to
The
tibial
toe
vessels.
pressure. Do you have an idea what is the pressure? What is the pressure on which we say that patient is suffering from peripheral vascular disease, and what is the ratio? But any idea? So for the toe pressure, if it is lower than 55 mm, then our toe brachial pressure is less than zero point 0.7, then we say that the patient is suffering from peripheral arterial disease. And if it is less than 30 mm, we say that the tissue is not going to heal. So for the persons to complete the list, ABPI, if we say that it is less than zero point 0.9, patient is suffering from peripheral arterial disease, and if it is less than zero point 0.5, we say that patient is suffering from critical limb ischemia. And if the ABPI is more than 1.3, it means that it is non-reliable, it means due to calcified vessels. Whereas toe brachial pressure, the vessels are spared. And if it is less than zero point 0.7, we say that patient is suffering from peripheral arterial disease. Do you know any other non-invasive test other than the ABPI, other than the toe brachial pressure, which can be used to assess a peripheral vascular disease? So we can use transcutaneous partial oxygen, we can use hyperspectral imaging, but the most common is this is a segmental pressure pulse volume recorder. You see that we have a triphasic pattern, which shows that normal arterial flow. Biphasic means moderate arterial disease. And then there is a monophasic, which shows that a severe peripheral vascular disease. So on the left leg, we see that the waveform is flattened. They are biphasic or monophasic. And that shows the segmental pressure, which segment is involved. So that can be used as a non-invasive test to diagnose and to locate the peripheral vascular disease. But the most common is use the ultrasound. I know you know the benefit of ultrasound. It is non-invasive, it can be repeatable, it's a cost benefit. You can actually check the flow dynamics. I will like the group to actually initiate what are the limitation of an ultrasound, especially in a patient with diabetes who have peripheral vascular disease. Any limitation? Asad, Anam, Pariyam, can you actually comment on that? Any limitation of ultrasound when, especially in diabetic or general ultrasound limitation?
So it's dependent on the person who's doing. It's basically user dependent. It's dependent on the
Very good.
person.
It is operator dependent. Very good. Excellent. Number two, any other limitation?
So the infrapopliteal vessels in diabetics have excessive calcification that causes acoustic shadowing and difficulty in estimating the flow in the tibial vessels. And secondly, the peroneal vessel and tibioperoneal trunk that are located in between the bone segments. So these are difficult to visualize accurately with ultrasound.
Very wonderful. And third is probably in between the bones, tibia and fibula, there is vessels running. And these vessels actually are not visible. The window cannot be seen. And that is one of the problem with these ultrasound. And then we have definitely edema. We have these skin ulceration, which limits our ultrasound scale. But that is very good investigation, which can be used as a non-invasive. And it can even actually give our category. Means patient is suffering from mild disease, less than 20%. We have Dr. Khalid with us. Assalamu alaikum, Dr. Khalid. Probably you are muted. I can actually. And then there is moderate peripheral vascular disease, which is more than 50%, and then that can be checked by peak systolic velocities and like this. There is some voice. Can other people can mute it only that. So we have the other investigation like a CTA. CTA is a good investigation. Actually, this is non-invasive and this can give me reconstructive, but there is some limitation. I want the group to come out. Please, can you come out with any limitation of the CTA? Now, Khalid, is Shafiullah with us? Can we comment on the Anam with us, or we have lost them?
Sir, I think, sir, as in diabetic, there is a calcification of the
Very
vessel. So the dye, as it looks, gets a whitish shadow, so it may give false impression.
Very good. Excellent. So basically, due to contrast, we cannot differentiate due to calcification and contrast. There is a problem. The calcification turns out to be as a contrast, and it looks like that there is a flow. So this and second problem is that we have discussed that intrapopliteal disease are mostly involved in diabetic, and there's a severe calcification, and so and that cannot give us good idea where the disease is there. Thirdly, there is a problem with radiation, and fourth is problem patient we are using contrast, and we know that most of the diabetics have problems with kidneys, they are nephropathic, so it can actually derange it up, but it can give good idea. For example, can someone comment on this CT image which is there? William, can you comment on this CT scan image? So, Dr. William Asad with us, yeah?
So, sir, it's a 3D reconstructed images of the CT angiogram bilateral lower limb showing the inferior popliteal reconstruction of the vessels, and we can see, on my opinion, it's basically highly calcified vessels, and of both the legs, that the TP trunk along with the peroneal and the posterior tubular artery is opacified. However, the anterior tubular artery is not properly seen because of the calcification.
So excellent. That is very good. But we see that there's a beaded appearance, this corded appearance of one of the vessel. This shows that it's the disease vessel.
Yes.
But if we see the AT, it is actually not as beaded. So it is filling with contrast. It means a patent, but it needs a very good reconstruction in the CT scan. But CT scan has limitation in the infrapopliteal vessel. But compared to DSA, digital subtraction angiogram, CT has near comparable accuracy for detecting stenosis more than 50%, and reported sensitivity and specificity is quite good also. So we have other imaging, which is MRA, magnetic resonance imaging. I know it is also non-invasive. It is very good modality. Is there any limitation which comes in your mind of using MRA in diabetic patients?
So it's a prolonged study. It takes
Very
time,
good.
and along with it, it's also contraindicated in kidney disease, can lead to systemic fibrosis also.
Very good. Excellent. And one particular problem with this is the venous contamination. If it is not properly done, the veins and the arteries due to flow looks normal. So this is one of the problem doing an MRA indirect. Secondly, it does not tell us about the calcification which are there, but it is very good modality in differentiating the lesion. Can someone comment on the MRA images which are there? Is Khalil Variam with us? Shafullah? Asad, can you comment on the MRA picture which is there?
So it's a MRI showing first picture showing the MRI picture of the abdominal aorta along with the common iliac vessels, and along with the along with the common iliac, external iliac, and the common femoral. The second picture is showing up the proper contrast opacification of the superficial femoral arteries along with the infrapopliteal vessels down on the third picture.
Yeah. So what we probably have been pointed, yeah.
And it's basically the disease process is at the level of the common iliac arteries. We can see there is which is more on the left common iliac artery as compared to the right side, but there is some disease process also on the right side of the
yeah, and otherwise it gives very good picture up to the ankle. This is very good modality. So if I have to prefer, so sensitivity detecting hemodynamic significance has been reported 94% for peripheral arteries using an MRA. So this is very good modality. But these definitely have limitations. The gold standard remains the conventional angiogram, which shows better infrapopliteal vessels, and images are not hindered by calcification, and it can be used both as a diagnostic and therapeutic purposes. But only problem is it is invasive. There are complications with the access site like pseudoaneurysm, AV malformation, and also bleeding. And then it definitely uses contrast. And in diabetic, we know that they are nephropathic. One of the modality we can use is a carbon dioxide angiography. That is not nephrotoxic, but then it does not actually give good images below knee. We can use up to the knee, and then below knee we have to use little contrast. But this is the gold standard which can be used as a as a basically not only diagnostic and therapeutic purpose. I will just actually little bit explore by Dr. Khalid and Dr. Zahid how they actually go about which imaging modality they select for a patient if come with critical ischemia. Do they rely on CT scan, MRA, or they directly go to conventional MRI?
Okay, if I can talk. So basically, if we feel that the patient is definitely going to need some intervention, we will do an arterial duplex scan. And if there's a suspicion that something is doable in terms of down the leg angioplasty, then we'll do a diagnostic down the leg angiogram with a view to an angioplasty at the same sitting. If there is some element of doubt whether what's the burden of calcification in the diabetic, then we would do a CT angiogram. The MRA is mainly used for calf vessels because usually the distal outflow is much better visualized, we find, with the MR angio. The problem with a lot of our patients is that they've had previous either stents, other intervention, which then is not very good with MRI because of the signal dropout with the stenting, and also a significant number will have hip and knee replacement surgery, which again interferes with the images.
Yeah. Sure.
Yeah, we also actually, Assalamu alaikum all. We also actually have almost the same view as Zahid just said. The only thing is that every center has their own unique investigations because of the expertise they have. Like in Nottingham, we used to have a excellent MRA consultants who would read the MRAs very well, and they preferred MRA over CT scan, and we used to get excellent images even for the foot and for the proximal as well. Whereas at the moment in the facility I'm in Abu Dhabi, we use the CT scans more because people are more used to CT scans and MRA. And I agree with Zahid that wherever we need to do look at properly in this facility where we should do distal below the knee vessels, I think the best is conventional angiography and do the procedure at the same time instead of doing the investigations first and then do another one. So you do the same time, investigate, do the angiography and angioplasty wherever is required. And that is, I think, is the way to go ahead. I mean, it depends upon the specialty, what expertise you have in your unit.
Yeah, that is excellent. Basically, angiography can be used both as a diagnostic and a therapeutic purposes, and it also depends on the center in which we are working. But you have to, for the juniors, I would say, you have to know about the limitation and utility of every investigation. So we can actually classify diabetic food depending upon different classification systems. One is the Wagner, which is the classic, but problem with that, it does not tell us about the ischemia. We have University of Texas, in which if we go on the last stage, it shows that it gives C for the ischemia and D for the infection and ischemia. But we need to improve. There is another classification system which everyone must be knowing is the Wi-Fi classification system. So anyone wants to comment what is Wi-Fi classification system and how it is used and what is utility than other classification system? Maybe Pariyam, Asad, Khalil, Anam, anyone?
Assalamu alaikum, sir. So currently a Wi-Fi scoring has been used internationally in different studies. Wi-Fi is basically is a wound ischemia and foot infection. Collectively, they have used as a like in a TMA and TNM staging. They have components. They have components. One is ischemia and infection.
Very good.
And they have classified this ischemia and infection, and they have made different slots, brackets. If the patient with the Wi-Fi is stage 1, stage 2, stage 3, stage 4.
Yeah, excellent.
And their patient landed in stage 4, is most probably landed in the amputation.
Very good. Excellent. Excellent. So
and
we have, please. Yes, Khalid, please.
Sir, the current guidelines, which has been societal guidelines, and used all the guidelines, European Society of Viscosity guidelines, they have currently used the Wi-Fi scoring in the treatment of the patients with the critical ischemia.
Very good. Excellent. This is the message I wanted to say, that this is a TNM system, just like a malignancy which is used. Is if we say that the patient has stage 1, it has very low risk. If they are stage 3 and 4, they are at high risk of limb loss. And this is the Wi-Fi probably you were talking, that is wound, ischemia, and Wi-Fi. We can use the ischemia using the ABPI, but we know the problem with the ABPI is calcified vessels in diabetes. Then we have to use the ankle pressure, and then we can categorize different type of the ischemia. And then depending upon the infection is simple or it has a surge, we can actually give the grades of the foot infection. And then this can be said that it is stage 1 to stage 5. Stage 1 is definitely very low risk, whereas stage 5 is unsalvageable. So this is the way we can use this Wi-Fi classification. Thank you, please. So This is just the idea. When you are deciding about a patient with critical limb ischemia, so you have to always keep in mind the natural history of the patient. For example, at 1 year, 20% of these critical limb patients are dead. 40% will be alive with amputation and 40% will be alive without amputation. Therefore, because if a patient presents with a critical limb ischemia, so you have to understand that he is suffering from diffuse atherosclerosis and it is affecting all its parts. So if I say it has same risk for coronary event, diabetes and peripheral as patient having ischemic heart disease, so I am not wrong. Because if a patient has ischemic heart disease, it has the same risk factor perioperative morbidity as a patient with diabetes and having peripheral vascular disease. So it is correct. You have to understand there. And whenever you are counsel, you have to counsel like this. So if a patient, for example, claudicant comes, so what is the treatment option? How you actually treat it out? Anyone? Asad, you can go. Shafi is with us. I see Anam was with us before.
So the first
Amna, yes, please.
So the first option for the treatment of claudican is always the conservative trial and exercise therapy. So so that for the development of good collaterals and avoiding of further claudication.
Yeah, very good. Good. So excellent. The claudicants has to be treated conservatively. You have to understand that this is a claudicants and the critical limb ischemia is the same disease, but at the different ends of spectrum of disease. Claudicants is a benign disease. 95% of the claudicants will improve with conservative treatment, whereas in critical limb ischemia, if you do not revascularize, they will end up in a major amputation. So they need revascularization. In the claudicants, we go for the optimal medical therapy and exercise therapy and some pharmacological. And our goal is to correct their our goal is to actually maintain their diabetes. And if you go with what is the guidelines, that what is the blood pressure level we have to maintain, what is the hemoglobin A1C level we have to maintain, and what is the level of we definitely have to stop smoking. Any idea about that? So I have just actually shown that the hypertension has to be less than 130/80. Hyperlipidemia, we target for LDH less than 70 milligram per deciliter. We go for diabetes control and we aim for hemoglobin A1C less than 7 ml. Definitely, as Asad has told us, that we have to go for supervised exercise. We say them to walk for 30 minutes and ask them actually go for at least for 4 days. And then aspirin has shown to be effective. We have to give one of the antiplatelets. But in a captive trial, it has been shown that clopidogrel is more effective. So you can add aspirin definitely or replace it with clopidogrel. And you can give silestazole. We have few randomized trials which have shown the effectiveness of the silestazole. So this is the option. And in 95% of patients, claudicants is going to improve. And you do not need any type of intervention. But in a lifestyle limiting claudication, you have to intervene it out. So if someone want to add on that, Dr. Khalid, you want to add on the treatment on this, or Dr. Zahid?
Sorry, sir, but pharmacological treatment also will include statins?
Yeah, definitely. If we have to correct the hyperlipidemia, we have to actually go for the pharmacological treatment. And for the same,
if the patient is not, it doesn't have hyperlipidemia, just to as a prophylactic treatment for, does the trial of the pharmacological include statins?
Yeah, I am not sure. Yeah, I am, but I will target for the LDH less than 70, and it has been shown that it actually it stabilizes the plaque. The anti-lipid medication can stabilize the plaque on that of that.
I think as far as silestazole is concerned, I use it very sparely in patients who have more severe claudication, and they are not diabetic, because obviously cilostazol action, mode of action is to dilate the blood vessels. And if in diabetics, majority of the patients do have calcification, and I found that cilostazol has not the same effect in diabetics as in non-diabetics. I don't know what Zahid, your experience is about it.
So our experience is that cilostazol is not actually licensed in Scotland, and so we have to give it as a private script. The one that we do use is Praxilene or Naftidrofural, which is quite an old drug, and I think it probably works in about 25% of cases, and you have to continue them for about 3 months before you can either continue them indefinitely if it makes a difference, or you stop after 3 months. The point about cholesterol is the hyperlipidemia is we treat everyone with a total cholesterol of greater than 3 millimoles because of the plaque stabilizing properties rather than actually lowering the cholesterol per se. But if they've got a total cholesterol less than 3, then we don't put them on a statin unless there's a specific indication. And again, I would totally agree with you with regards to the clopidogrel. The Caprice study showed that, especially in diabetics, clopidogrel was far superior than aspirin. So we tend to use clopidogrel for the diabetics and aspirin for the non-diabetics. Thank you.
That is excellent point. So this description is for a typical claudicant, and in diabetics we know that most of the diabetics do not present like a claudicant. Like if they present, then we have to switch to this treatment. But if patient present with a critical limb ischemia, we have discussed that they do not have time for making revascularization, and these patients definitely need some form of revascularization. Options we have the open, endovascular, and the hybrid. Is Dr. Ford with us? Dr. Ford. No, okay. So this is the algorithm I am going to take, that in a patient who have a wound, and we have first to control its infection. We have to do some imaging and manage it up, do debridement, and offer the offload. But if we do not improve its blood supply, the wound is not going to heal. There's not going to be granulation tissue. So this is our aim of wound healing should not be only revascularization. We have also to correct diabetes. We have also to see how we can improve the wound healing by offload and doing debridement. And the holistic means correcting patients' systemic problems also. But the main focus is improving the blood supply. And surgical bypasses are durable, and we have very fortunate, we have Dr. Zahid with us, Dr. Khalid with us, and I will ask them just to give some comments on what is the role of surgical bypasses in patients with critical limb ischemia who have diabetes, and what is their experience, what type of conduits they are going to use, are they using reverse, non-reverse, in situ, and in which particular patient they select the surgical, and which patient we take for the endovascular. Have their approach changed over the recent years with more advent of endovascular therapy?
So for ourselves in Edinburgh, what we tend to do is look at the age first of all, because there is no doubt that if you're going to do an ultradistal bypass or any form of distal bypass, which most diabetics will need, you need to have a fairly young patient. What I mean by that is someone who's under the age of 70 would be considered young. For the main reason being that they're fitter, and also they have to have a decent outflow for the bypass to work. I remember my best bypass done was in a 35-year-old diabetic, and he had popliteal to pedal bypass, and that lasted for at least 10 years, and then he was lost to follow-up. So I think you have to select your patient very carefully. The older patients who are not as fit, they get what we call, a salvage procedure. We're trying to do something, radiologically to try and improve the perfusion to the foot, but they're not really suitable for bypass procedures. But generally speaking, bypass is technically much more challenging in the diabetic patient because you're dealing with the crural vessels mainly. But I think it's important to select your patient very carefully to see which ones will do better.
Yeah, excellent. Doctor, any comments, Dr.
Yes.
Khalid?
Yes, I think you asked the question whether the view have changed over the years, and I must say yes, it has. I mean, we used to do a lot many bypasses for these patients with critical limb ischemia, but over the years, with new advent of this endovascular approach, we are more, these have become the first line management for majority of the patient, except for selected ones where you do the bypass first, and it depends upon patient to patient. And I think Zahid's point is very valid, and that the age is which is one of the most important things which actually you can select which patients need to do a bypass or not, because majority of these patients have a lot of comorbidities and they are old, and these patients don't do very well with bypass surgery, especially when the runoff is also very bad. So it is important that we have to select the patient, which I have very nicely put on. That's we have to select the patient properly, and keep your mind open. But with these advances in endovascular approaches, with stenting, with different type of balloons, with drug-eluting balloons, and all these things have changed our perception, and endovascular has become the first line as compared to the bypass, but still bypass has its place, and we have to select the patients, the winners for the surgery.
Yeah, these are good points. So we are better.
Sorry, could I just make may I just make another point?
Sure.
I totally agree with Khalid. I think one of the things that the trainees need to be aware of is that sometimes we're doing an angioplasty, and what we're looking for is to heal up the wound. Now, we know that most angioplasties, probably about 50%, will reocclude at 6 months, but that window of opportunity that you have, maybe 3 months of the angioplasty working, is enough to get the wound to heal up, and even if it does block off at that point, then at least you've got a healed wound, but you're back to your kind of a claudication situation, but at least then you don't have an open wound. So angioplasty is, despite the fact it doesn't have the patency that a bypass has, is still very useful in that situation.
Very good. This is the point. Although they are durable, but and better outcome than complex endovascular and good quality, but success of the surgical bypass depends on the venous conduit and meticulous post-operative surveillance. Probably the arteriogenous vein, whenever the vein is available, is done. There is a discussion which we are doing at open and endovascular. This continues, and there is little bit lack of prospective randomized trial. So for the open surgery, there are many techniques we can use as a reverse, we can use as a non-reverse in situ, and we can also perform the endarterectomy, the Linton patch, or we can use distal bypasses of different configuration. But results, as Dr. Zahid has said, that is excellent, especially when the vein is used. For example, for the femoropopliteal, which is most common bypass, has shown 5 and 10-year patency of 83 and 63%, and the limb salvage is 89%. But mostly diabetic patient has intrapopliteal disease and pedal bypasses are used. They have also very good report. This is actually a 10 studies review which has shown that the patency is ranges about 78 to 86%. So, but the issue is that with endovascular, this probably has changed. Now, endovascular has become the I will say the treatment option number one. If it heals the wound, that is done. Patient becomes claudic and that is. I'm just going to a concept which is bit not new, but I just wanted for the juniors to explore it. Can someone comment on the angiosome concept? What is this, and does it help in our bypass surgeries or in diabetic patients? Any idea? Can Variam, Asad, Khalil can comment on this?
So it's a distribution of the foot areas along with the vessel supplied to that particular area.
Yeah.
Like for example, the dorsum is supplied by anterior tibial, and then we have the plantar aspect supplied by different vessels. But I'm not sure about the results of these bypasses on the based on the angiosome concept. That how we are sure that if we particularly vascularize that vessel, will completely heal the ulcer or not.
Yeah, I agree. There are lack of evidence for that, and we have only the retrospective studies and with the different results. Some people saying that in bypass surgery it does not work, but in endovascular we have to go for the angiosome concept. For those who do not know, angiosome is an anatomical unit of tissue fed predominantly by one source artery. There are 6 angiosomes which has been described in the foot. 3 for the posterior tibial artery, calcaneal branch, medial and lateral plantar artery. 2 for the peroneal artery, that is anterior perforating branch and the calcaneal branch, and 1 is the anterior tibial artery, which becomes the perforating artery. So this is different angiosome concept. So there are 2 types of revascularization. One is a direct and one is indirect. If we go through the angiosome concept and the wound is there, this is known as direct revascularization. And if we do for the indirect, and the results are variable. And but the idea is to get pulsatile flow up to the ankle or one of the pedal arteries to heal the wound. And in endovascular therapy, if you get a vessel which is in the angiosome, probably it is better to open it up and help in the wound to heal. And if we have discussed that endovascular approach is fast. It is done in local anesthesia. Most commonly, it is done PTA and with a simple balloon or with a stent. And we have cross classification. Although the classification is there, but it is of little practical use because for the class D, which is recommended for surgical, people are even using endovascular therapy, and it works. It makes the sense. We can use in diabetic contralateral access or the antegrade access. What I wanted to prove to comment a little bit what is antegrade and what is the contralateral access and how it makes the difference, especially patients with infrapopliteal disease. So any idea about that antegrade? What you will select, the antegrade access or contralateral access in a diabetic patient?
If it depends on the lesion, the location of the lesion. Like for example, if it's the level of common femoral, we can go up and over technique, the contralateral access from the contralateral side, and we can treat the disease process on the lesion. But for the infrapopliteal process, infrapopliteal lesion of the ipsilateral side, I think the antegrade access of through the same leg is more easier because of easy. What can I say? Maneuverability.
You need a small. You do not need longish catheters and guide wires, and your torqueability is quite good. But only thing is
Exactly.
that you have to rule out,
Coachability and
yeah, you have to rule out this basically proximal lesion, either doing a ultrasound at the femoral or iliac vessels, and you have to rule, because although we say that diabetics have infrapopliteal disease, but they can have the proximal lesion. It has to be ruled out, and the palpable popliteal pulse does not rule it out. But it is basically, there's some little complications associated, more local complications than a retrograde approach, and the flow year may be a problem. But for working, it is quite good. It gives an inline actually flow. So antegrade approach in a diabetic, if the palpable pulse is there, is no proximal lesion, you can select it up. You want to comment on anything else?
no, sir. This is, I think, this is the main reason of just discussed about both excesses.
Yeah. And then probably there's innovation in endovascular therapy which is going on. We have drug-coated balloons, which they have, for example, sirolimus, which decreases the intimal hyperplasia and decreases the actually restenosis. We have stents which are available, and they do help in decreasing it up. These calcified vessels in diabetics actually prevent simple balloon angioplasty. To facilitate it, we have atherectomy devices, which actually devolve the atheroma and help the angioplasty to do it. We have cryotherapy, brachytherapy. We have good prospective studies which have shown the efficacy of the drug-coated balloons and stents and atherectomy device. And these are commonly used. And probably this is the reason probably the endovascular is becoming the first choice in this patient. Then there has been also innovation in endovascular therapy in approaches. For example, the most important approach is the antegrade approach, in which we go through the lumen and do the angioplasty. But it may not be possible, especially in the complete occlusion. We can use the retrograde approach to the pedal vessels, and it has shown to be also effective. Then we can use the subintimal approach and even the safari approach, in which we can use retrograde and antegrade and then actually cross the leonita. And then there are options of doing hybrid. For example, if patient is having any plaque in the common femoral, we can use the endarterectomy and do a distal. Instead of doing a bypass, we can do proximal or distal angioplasty. So these are the ways. And these all has shown to be quite effective in healing these patients. So any comment on this innovation in endovascular therapy by Dr. Khalid, Dr. Zahid, Dr. Faz? If he's with us.
I know our radiologists use the very fine wires for the retrograde transpedal approach occasionally. The subintimal approach has been well established, but again, with the very heavily calcified vessels, it sometimes is not as good as doing it in the non-diabetic patient. And we have very little experience on atherectomy devices. But certainly they use drug-coated balloons and stents, which have shown a far superior patency than just using angioplasty balloon alone.
Thank you.
Our guys here, if they fail the antegrade approach, majority of the time, the retrograde pedal approach works, and drug-eluting balloon is more and more. They are using more and more drug-eluting balloons as compared to simple balloons, and nowadays even stenting is becoming more liberal, even in the popliteal, although still the distal vessels are spared. But popliteal, if they recannulate the popliteal, then they normally put a stent as well. But we discourage them. Still, we discourage them, although it has shown some good promising results with superior stents and things like that. But we still discourage them to put any stents in the popliteal. But these are the few things which are becoming more and more common nowadays.
Okay. Thank you. Dr. Faz?
Sir, Assalamu alaikum.
Yeah.
Sorry, I just went for Namaz before joining late. Actually, I attended a VEET symposium pretty recently regarding these critical ischemia patients, especially diabetics and CRF patients. They, as Dr. Makhdoumi mentioned, that there have been quite some innovation in using the stents. Now they're also suggesting use of stents such as Eluvia and things for below the knee popliteal vasculature. However, they also made it a point. The point I got from it, that they also that they don't give up on the foot that easily. The things that we think at times that might be unsalvageable, maybe because of our limitations, you don't just give up on them. Surgery still remains a lot of has a lot to offer, especially in the small vasculature of pedals and things like that. But the point I got from that presentation was that in patients diabetics and things like that, you have to have a multidisciplinary approach, and combining that with the innovations, if these are possible for you, fine. But even if it's not, you can still you have to go to the limit to try to save these limbs. But not at the so that's what I got actually from that point.
It is a philosophy.
Another point I want to make was that there are certain centers who actually try to recannulate and the arch of the foot, recreate the arch of the foot. They go from the anterior and posterior and they balloon the whole of the arch.
Yes.
They said it works, but very limited centers are doing it. And in our centers, we don't do it, although occasionally I do encourage my interventional radiologists to at least try, because the patient is going to, probably end up with an amputation. So, but they haven't been brave enough to do it at the moment.
Yeah.
But just sir, I'm sorry, just one more point. Having said that even all those interventions work and things like that. We recently had a patient who was a 75-year-old patient having so many comorbids, and his diseases, he was managed elsewhere and referred to us late. So he was such a sick patient that even in that, and why he was referred to us was that the ultrasound was showing severe PT insufficiency when his all even the bones of the heel were exposed, and he was persistent on doing an endovascular approach for him. When I counseled him that BKs for him is a better option, so we need to realize this as well, that at times we are referred patients which do not have a salvageable foot, and for them amputation is the better option. And however, because of the miscommunication and the existing gap that still needs to be filled between different specialities, this remains an issue to be addressed, I guess. Thank you.
Yeah, that is a very good point. Because if we say that what is the treatment option, there is a medical treatment, there is endovascular treatment, there is surgical, and then there is amputation, which can be life-saving. So, Dr. Faz, you are doing some lower leg angioplasty, I believe. So,
Sir, we just have, considering the limited inventory that we have, we do lower limb angioplasties, but that's all that we have. We don't have drug eluting balloons, but yes, we do below the knee angioplasties for them.
So just
however, sorry, sir.
Yeah, continue, please.
However, sir, the lack of an inventory has led us to do more distal bypasses, and the results of these are, of course, fantastic.
Very good, thank you. So what I wanted to convey that for below knee revascularization, we use the low profile coronary devices, which has improved outcome. Imaging is the key because we need the road mapping, we need know the overlay technique, we need an angled methods because in between the bones it can come. We use guide wires 0.018 and 0.014 for our system. And both hydrophilic and non-hydrophilic wires are used intelligently to cross the lesion. So this is the below knee basics of below knee revascularization. This is some of the images which are showing how the revascularization has been done of the anterior tibial artery. So this is the common femoral showing the profunda and SFF which is blocked, and through a wire which has been placed and angioplasty done, showing revascularization of that. Sometimes we see the proximal stenosis. So, and this is intra-renal aortic stenosis, and a balloon has been placed which has dilated the stenosis quite well. This is the patient who have bilateral superficial femoral artery lesions and a long balloon which has actually able to dilate it up. So the problem, the complex problem is crossing the CTO. So we have a drilling technique, we have penetration technique, and we have parallel wire technique. In a drilling technique, what we do, we angle the guide wire and just actually drill it up and cross the lesion. But it can bend, it can go subintimal, that's the problem. Then we have penetration technique in which we place the stiff guide wire and try to cross the lesion. But it also is technically challenging. And then we have parallel technique. And then, as Dr. Khalid has told that, we can use retrocade, that making a pedal plantar arch loop. Even we can actually revascularize to a collateral. These are the innovations in below knee popliteal artery. And this is the results. How many vessels has to be opened? Any idea when you get a patient with infrapopliteal vessels, if one vessel is open, do you go for another vessel revascularization or are very satisfied with one vessel? Any comment, Dr. Fahd, Dr. Khalid? Means there are three vessels. Do you go for opening, you attempt to open all these three vessels, are very satisfied if one vessel is open and it is actually revascularizing it up?
Yeah.
I think it's... go
Sorry,
on.
Zahid, you carry on.
No, please go. No, please, Khalid, go.
I mean, the thing is that if there is no tissue loss,
yeah,
then I would be satisfied with a good single vessel. But if it is possible that the short stenosis in the other vessel, then I would go for angioplasty of that short stenosis. But sometimes what happens is that the occlusion of the whole vessel, you have to do a subintimal angioplasty of the whole anterior tibial, or majority of the anterior tibial, or one or the other vessel. Then in that case, you recannulate one vessel with no tissue loss. If there's a tissue loss, then that's a different issue, and then you have to judge whether it will heal or not, or you do it in two different stages. But I think no tissue loss, single vessel, but if there's a short stenosis in the other vessel, then yes, we can do it. But if it is recannulation, then it will be a difficult one.
Yeah, I was actually going to say something very similar to what Khalid is saying. The other thing, what I've noticed our radiologists do is if they are going to open up two vessels, then sometimes it's necessary to have two wires down the leg, because one for each vessel, because what tends to happen, so for instance, if you had a lesion at the say the tibioperoneal trunk and you were trying to open up the anterior tibial and say the posterior tibial, you might need to put two wires in, because every time you angioplasty, say the tibioperoneal trunk, you might compromise the origin of the anterior tibial. So in order to open up the two vessels, you might have to put in two wires to prevent compromising the one that you've just opened up by angioplasting the other one.
That is great. So,
can I ask if I could, do they put two balloons at the same, use the balloons in both arteries, or they only put the wire and use the balloon in one artery?
So what they do is they will put the wire in the artery that they've just angioplasted and just park it there, and then they would balloon the other side, the other vessel, and then do a run. And if there is no problem with that, the one that the vessel that they put the wire in, then that's fine. Otherwise, they will re-angioplasty that. I think it's just to make sure that they've got access to these vessels, and as they are angioplasting them, kind of cross a form of affecting the treated vessel, if you see what I mean.
That's good.
Yeah. So this is actually the results of a systemic review, which I have shown that a combination of surgical, endovascular, or hybrid methods have given the skin salvage rate of 80 to 85%. So, right. So this is actually our results that we have done 32 bypasses, and our salvage rate was about 90%. We have some systemic complication. 3 patients have non-fatal MI, few have renal failure, minor complications, but bypasses works even better. So in the end, before I see 2 persons which I definitely wanted to listen. One is Dr. Zia Sufi. I see that he has signed. What is your actually comment? How you will assess the patient, and what is your message? Where you place bypasses and Dr. Zia with us, and we have also Dr. Waqas with us. Probably we can see them later. So what I said, that peripheral vascular disease is quite common. 50% of the diabetes has peripheral vascular disease, and outcome of these patients is not good. And these patients have atypical presentation. They do not present like a intermittent claudication. They present like do not present with rest pain. The very first presentation with a tissue gangrene or a ulcer. So the investigation, for example, the sugar API is not confirmatory, and we have to go other non-invasive investigation. Time tissue, early detection and referral, and organized program in developed countries have make a difference, and that we can duplicate in our country also. And limb salvage, as Dr. Far, said by Dr. Far, limb salvage is a philosophy in which team members like endocrinologists, general practitioners, even prostate surgery people have one idea to salvage the limb. Then it makes a sense. And revascularization is the key. This is a small session which we have done. If there's anything you can say, there's any comment, there's any question, please.
There was a question in the somebody wrote a question.
Yeah.
And about clopidogrel and aspirin. I don't know whether that person is still there or not. What our approach is that we usually use dual antiplatelet in the beginning when the patients have long stents or long angioplasty for at least 3-4 weeks, and then change it to a single antiplatelet, either aspirin or clopidogrel, and preferable is clopidogrel because for obvious reasons. But this is what our approach is over here. I don't know what Zahid, what you do in these patients, dual antiplatelet or single antiplatelet in patients with after intervention.
Yeah, well, we do dual antiplatelets for 6 weeks and then put them on single antiplatelet therapy.
Yeah.
So if there's any questions, I actually really thank you everyone for participating in it, especially Dr. Maktoumi, Dr. Zahid, Dr. Fad. I see Dr. Waqas here, Dr. Zaid Sufi here, and Nadeem. So I thank you everyone. Hopefully we will organize other sessions like that, and your participation will be highly appreciated. Thank you.
That is excellent. Thank you very much for inviting us.
Thank you.
Thank you, Dr. Zia.
Yeah, thank you very much.
Thank
Appreciate
you,
it.
everyone.
Assalamu alaikum.